First, information about hemodynamics. Hemodynamics is a section of the physiology of blood circulation that studies the causes, conditions, and mechanism of blood movement in the cardiovascular system. The movement of blood in the system, in the circulatory system, is determined by two forces. First is the pressures under which it's in the vessels, and the resistance, second, that occurs when it passes through the vessels. The driving force of blood movement is the pressure difference that occurs at the beginning and end of the vessels. Factors affecting blood flow. Blood flow, volume of blood that flows through any tissue in a given period of time. In units, milliliters per minute. Next, information about total blood flow is cardiac output, volume of blood that circulates through the systemic or pulmonary blood vessels each minute. Formula for check cardiac output you can see on slide. Cardiac output equal heart rate multiplied to stroke volume. And distribution of cardiac output depends on pressure differences that drive blood through the tissue, flows from higher to lower pressure, and resistance to blood flow in specific blood vessels. Higher resistance means smaller blood flow. Next, information about dynamics of blood circulation. Interrelationship between pressure, flow, resistance, control mechanisms that regulate blood pressure and blood flow through the vessels. Basic laws of hemodynamics. Poiseuille's law. Poiseuille analyzed the study flow of liquid through the capillary tube. He derived an expression for the volume of the liquid flowing per second through the capillary tube. As per the theory, the flowing condition must be related while deriving the equation. The flow of liquid through the tube is straight lines. The tube is horizontal so that gravity does not influence the flow. The layer in contact with the wall of the tube is a rest. The pressure is uniform over any cross-section of the tube. Peripheral resistance in vessels, according to Poiseuille's formula, depends on length of vessels, viscosity of blood, and cross-section of vessels. R equal 8 times to length of vessels, viscosity of vessels, and divide on P times to cross-section of vessels. In accordance to this formula, the highest peripheral resistance might be in the smallest vessels In really, the highest resistance is observed in arterioles. Average blood flow resistance in adults is equal near 900 to 2500 din on seconds per centimeters by fives. Hemodynamic resistance of single vessels, on picture you can see is R, directly proportional depends on the length of the vessels, blood viscosity, and inversely proportional from vessel radius to the force power. Analysis of this formula shows that vessel's radius is the most important factor affecting the hydrodynamic resistance. For example, if it's decreasing by 3 times, then hydrodynamic resistance increased by 81 times. Since hydrodynamic resistance in the blood vessels of various organs are significantly different. Each organ receives its share of CO depending on the total hydrodynamic resistance of its own vessels. Adaptive change in the blood supply of organ in accordance with the needs are carried out both by change in cardiac output and by changing the hydrodynamic resistance of various parallel vascular network. On table, on figure, you can see different tubes and you can see formula for check Poiseuille's law for different tube. Next, information about characteristic of blood flow. And first time, characteristic about laminar blood flow. Blood usually flows in streamlines with each layer of blood remaining the same distance from the wall. This type of flow is called laminar flow. Laminar flow is a normal condition for blood flow throughout most of the circulatory system. It is characterized by concentric layer of blood moving in parallel down the length of blood vessels. The highest velocity is found in the center of the vessel. The lowest velocity, near zero, is found along the vessel's wall. The flow profile is parabolic once laminar flow is fully developed. This occurs as long, straight blood vessels under steady flow condition. Parabolic forms you can see on pictures from left side. Right side show movement blood through the vessels. Blood flow with form parabolic. Characteristic of turbulent blood flow under condition of higher flow, particularly in the ascending aorta, laminar flow can be disrupted and become turbulent. When this occurs, blood does not flow linearly and smoothly in just layers, but instead the flow can be described as being chaotic. Turbulent flow also occurs in large arteries at branch points, in diseased and narrowed, like stenotic or partially obstructed, arteries, see figure below, and across stenotic heart valves. Cause of turbulent blood flow: higher velocity, sharp turns in the circulation, rough surface in the circulation, and rapid narrowing of blood vessels. On scheme, you can see turbulent blood flow. On left pictures, you can see constriction vessels and change blood flow to turbulent flow. Reynolds number. The Reynolds number is the dimensionless number that is used to predict whether the blood flow will be laminar or turbulent. It considers a number of factors, including diameter of the blood vessel, mean velocity of flow, and viscosity of the blood. Thus, Reynolds number equal density of blood times to diameter of blood vessels times to velocity of blood flow and divide on viscosity of blood. If Reynolds number is less than 2000, blood flow will be laminar. If Reynolds number is greater than 2000, there is increasing likelihood that blood flow will be turbulent. Values greater than 3000 always predict turbulent flow. The major influence on Reynolds number in the cardiovascular system are change in blood viscosity and change in the velocity of blood flow. Paradoxes of blood flow. In the case of blood flow through the vessels with a diameter smaller than 1 mm, blood viscosity decreases. This is directly proportional. The smaller the diameter, the lower the viscosity. This so-called Fourier's linguistic phenomenon. In this case, the viscosity decreases due to the longitudinal orientation of erythrocytes relative to the axis of the vessel. Such an erythrocyte chain moves in a shell made of plasma which has a low viscosity. Second paradox, it was established that blood viscosity decreases with an increase in the flow rate. This is due to the central placements of erythrocytes in the flow. And last, the volume of blood ejected by the heart fills the vascular system. The next portion of blood will be able to fit in the vessels only due to the stretching. Accordingly, the less the gray hairs are stretched, the greater resistance the heart must overcome in order for blood to flow through the vascular bed. Next, information about structure of blood vessels, like main component of cardiovascular system. Wall of vessels consist of intima, is endothelium, this simple squamous epithelium, may have subenthelial layer in 1 mm or larger, tunica media, layer of circular smooth muscles, lamina, layers of elastin and collagen, internal and external, thicker in arteries than veins, maintain blood pressure, and adventitia, tunica externa, longitudinally running collagen and elastin for strain and recoil. On picture you can see structure of wall, arteries and vein. Different thickness have different layers in arteries and vein. Next, information about different vessel type in circulation. The main distributary arteries that depart from the aorta successively branch into smaller arterial vessels until they become capillaries. These smallest vessels join together to form veins, which then continue to join other veins until they enter the superior or inferior vena cava, which return blood to the right atrium of the heart. Different types of vessels are known in the following figure. This you can see different type vessels and different function types of vessels. Distribution, resistance, exchange and capacitance. This vessel you can see on scheme. Start from aorta, large artery, small artery, arterioles, capillaries, venules, vein, and big vena, vena cava. The relative size and function of different blood vessels are summarized in the following table. Look on first line. This you can see name different vessels, vessel type. Second line show diameter in millimeters and last line show function. And start from aorta. Near 25 millimeters in diameter. Function, pulse damping and distribution. Large arteries, diameter from 1 to 4 millimeters. Distribution of arterial blood flow is main function. Small arteries from 0.2 to 1 millimeters in diameter have function, distribution and resistance. Arterioles, small diameter from 1.01 to 1.2 millimeters, have main function, resistance, regulation pressure and flow. Capillaries, next type, equals 0.006 to 0.01 diameter in millimeters. Main function is exchange different substances and gases. Next type, venules, diameter of vessels from 0.01 to 0.2 in millimeters. Main function: exchange, collection, and capacitance. Next type is veins with diameter from 0.2 to 5 millimeters with main function capacitance like blood volume. And last type is vena cava, big vena, diameter 35 millimeters. Have function collection of venous blood. Next, information about functional types of vessels. The aorta, the main vessels to distribute blood to the arterial system, dampens the pulsate pressure that results from the intermittent outflow from the left ventricle. The actual damping is a function of the aortic compliance. Large arteries branching of the aorta. These carotid, mesenteric, renal arteries distribute the blood flow to specific organs. These large arteries capable of constricting and dilating serve virtually a role in the regulation of pressure and blood. Once the distributing artery reaches the organ to which it supplies blood, it branches into the smaller arteries that distribute blood flow within the organ. These vessels continue to branch and become arterioles. Together, small arteries and arterioles are involved in the regulation of arterial blood pressure, as well as blood flow within the organ. These vessels respond to change in nerve activity and circulating hormones by constricting or dilating. Therefore, these vessels are called resistance vessels. Second type vessels. When arterioles decrease in diameter, they are called capillaries and represent the smallest vessels in the microcirculation. Capillaries are the main exchange vessels in the body. Oxygen, carbon dioxide, water, electrolytes, proteins, metabolic substances, and byproducts pass through the capillary endothelium. When capillaries connect, they form post-capillary venules, which all serve as exchange vessels. As the post-capillary venules fuse to form larger venules, smooth muscles repairs. Venules form larger veins that serve as the body's measured capacity vessels. It where most of the blood volume resides and where regional blood volume is regulated. Different type vessels you can see on these pictures. This present capillary and post-capillary vessels, pre-capillary, capillary, and post-capillary vessels. Next type vessels are shunt vessels, a blood vessel that links an artery directly to a vein allowing the blood to bypass the capillaries in certain areas. Shunt vessels can control blood flow by constriction and dilation. In endotheliums, the shunt vessels dilate in response to cold therapy, cutting of the blood flow to the extremities and preventing heart loss. Arterial anastomosis provide alternate pathway, these collateral channels, for blood to reach a given body region. If one branch is blocked, the collateral channels can supply the area with adequate blood supply. This function arterial anastomosis. Elastic arteries, largest arteries, act as conducts from 1 to 2.5 centimeters diameter, largest diameter but walls relatively thin. Function as pressure reservoir, help propel blood forward while ventricles relaxing, also known as conducting arteries. Conduct blood to medium-sized arteries. On scheme you can see big vessels, this aorta, with elastic function. Big vessels give blood continue to flow toward capillaries. Arteries, aorta and its branches carry blood away from the heart, from big to small. These are categories elastic, muscular, and arterial types. Pressure diminishes along the cord. On figure you can see structure of wall in elastic artery. Muscular artery act as distributing arteries, middle size from 1 cm to 3 mm. Change diameter to differentially regulate flow to organs as needed, internal as well as external elastic lamina. Most of what we see as arteries, tunica media, contains more smooth muscles and fewer elastic fiber than elastic arteries. Wall relatively thick, capable of great vasoconstriction, vasodilation to adjust rate of blood flow, also called distributing arteries. On figure you can see structure of tunica media and different layers, and tunica media and tunica externa. These layers. Metarterial has precapillary sphincter, which monitors blood flow into capillary. Sympathetic innervation and local chemical mediators can alter diameter and thus blood flow and resistance. Resistance vessels. Resistance is opposition of blood flow. Vasoconstriction can raise blood pressure. On picture you can see small arterioles and effect change lumen from higher to lower, decrease diameter of lumen. Next, information about capillaries, smallest blood vessels. Connect arterial outflow and venous return. Exchange vessel. Primary function is exchange between blood and interstitial fluid. Like tunica media and tunica externa, substances pass through just one layer of endothelial cells and basement membrane. Capillary beds arrive from single met arteriole. Vasomotion, intermittent contraction and relaxation. On scheme you can see reaction, vessels and movement blood through the capillary beds. White color show point with different type sphincters. Next, information about systemic blood pressure. The pumping action of the heart generates blood flow through the vessels along a pressure gradient, always moving from higher to lower pressure areas. Pressure results when flow is opposed by resistance. Systemic pressure is highest in the aorta. Decline throughout the length of the pathway is 0 mm of mercury in the right atrium. The steepest change in blood pressure occurs in the arterioles. System blood pressure are not equal throughout the cardiovascular system. If they were equal, blood would not flow. Sinus flow requires a driving force, a pressure difference. The pressure difference that exists between the heart and blood vessels as a driving force for blood flow. Table provides a summary of pressure in the systemic and pulmonary circulation. First line shows location, the systemic and pulmonary circulation, and second line shows mean pressure in different vessels. First time in aorta. You can see 100 value, 100 millimeters of mercury in aorta. Large arteries have same pressure near 100 millimeters of mercury, systolic near 120, and during diastole 80 millimeters of mercury. Arterioles, this you can see decrease blood pressure equal 50 millimeters of mercury. Capillaries decrease pressure to 20 millimeters of mercury, and vena cava, this pressure in venous system equal near 4 millimeters of mercury. Last point, right atrium have pressure from 0 to 2 millimeters of mercury. In pulmonary circulation, pulmonary artery have higher pressure near 15 millimeters of mercury and change during systole and diastole. During systole equal 25, during diastole near 8 millimeters of mercury. In capillaries, 10 millimeters of mercury, this value. pulmonary vein have 8 millimeters of mercury, and last part, left atrium, pressure equal near from 2 to 5 millimeters of mercury. On figure, the smooth curve gives mean pressure, which is highest in the aorta and large arteries and decreases progressively as blood flows from the arteries to the arterioles, to the capillaries, to the veins, and back to the heart. Mean pressure in the aorta is higher, averaging near 100 millimeters of mercury. This higher mean arterial pressure is a result of factors cardiac, like systolic volume, speed of blood ejection from the ventricles, and heartbeat. Vascular factors condition vessels with elasticity of compensatory arteries, tone of resistive vessels, and volume of volume vessels. And last factor is blood factors, volume of blood, viscosity of blood, and hydrostatic pressure of blood. Next, information about kinds of arterial pressure. First, information about diastolic pressure. The lowest arterial pressure is measured during a cardiac cycle and is the pressure in the arteries during ventricular relaxation, maybe during diastole, when no blood is being ejected from the left ventricle. Next, information about systolic pressure is the highest arterial pressure measured during a cardiac cycle. Is the pressure in the arteries after blood has been ejected from the left ventricle during systole. Pulse pressure is a difference between systolic pressure and diastolic pressure. If all other factors are equal, the magnitude of the pulse pressure reflects the volume of blood ejected from the left ventricle on a single beat, or the stroke volume. Pulse pressure can be used as an indicator of stroke volume because of the relationship between pressure, volume, and compliance. Next, information about mean arterial pressure is the average pressure in a complete cardiac cycle and is calculated as follows formula. Mean arterial pressure equal diastolic pressure plus 1 to 10 pulse pressure. Notice that mean arterial pressure is not the simple mathematical average of diastolic and systolic pressure. This is because a greater fraction of each cardiac cycle is spent in diastole than in systole. Thus, the calculation of mean arterial pressure gives more weight to diastolic pressure than systolic pressure. Interestingly, the pulsation in large arteries are even greater than the pulsation in the aorta. On slide you can see difference factors for regulation mean arterial pressure. Green color show factors volumes, increased blood volume, skeletal muscle pump, like skeletal contraction, respiratory pump during breathing, and vasoconstriction. These factors give effect increase venous return. Second lines show connection between venous return, increased sympathetic impulses and decreased parasympathetic impulses. Like result, give effect increase heartbeat and increase stroke volume. This type give effect increase cardiac output and, like results, increase mean arterial pressure. Blue color boxes show change of blood in body. Increased number of erythrocytes like polycythemia and increased body size give effect increased blood viscosity and increased total blood vessel length. And with decreased blood vessels radius give effect increased systemic vascular resistance. Like results, have effect increase mean arterial pressure. Arterial blood pressure variations. Arterial blood pressure varies among individuals and in the same individuals from time to time. It's lower in children than in adults and increases gradually with age. It tends to be higher in those who are overweight. During sleep, it decreases, and during exercise and emotional excitement, it increases. Abnormally higher blood pressure, when sustained above healthy level at rest, is known as hypertension. When blood pressure remains below normal levels, the condition is called hypertension. Hypertension is associated with an increased risk of various forms of cardiovascular disease. Hypertension can be caused by sudden loss of blood or decrease in blood volume and may result in dizziness and fainting. Classification of arterial hypertension is carried out according to the level of blood pressure or cardiovascular status. However, priority is given to cardiovascular status. On slide you can see classification of hypertension 1999, European classification. First line show indexes, optimal arterial pressure. Second line shows systolic and last line shows diastolic arterial pressure. Optimal arterial pressure equal near 120 millimeters of mercury and diastolic less 80 millimeters of mercury. Normal arterial pressure equal near 130 millimeters of mercury and diastolic 85. Higher normal arterial pressure equal between 130 to 139 and diastolic between 85 and 89. This you can see difference degree hypertension. First, second and third degree and different isolated systolic hypertension measure hypertension. Second slide show information about American classification in 2003 Yes. Index, normal arterial blood pressure equal less 122 systolic and less 82 diastolic. Pre-hypertension condition equal between 120 to 139 millimeter of mercury for systolic blood pressure and 80 to 89 for diastolic blood pressure. Hypertension first degree equal systolic from 140 to 145 millimeters of mercury and diastolic from 90 to 99 millimeter of mercury, and hypertension second degree more like 160 for systolic blood pressure and more like 100 to diastolic blood pressure. Next, information about methods of blood pressure measurement. There are two types methods: invasive and non-invasive. Invasive method, it measures blood pressure internally by using a sensitive catheters inserted into the superficial artery. This is a procedure taken where continuous blood pressure monitoring is required. Non-invasive blood pressure methods are auscultation, oscillometry, Doppler, arterial tonometry, and palpation methods. On slide you can see non-invasive blood pressure auscultation and oscillometry. Indirect method of blood pressure measurement. Method by palpation, this is Rivarocci method. Auscultatory methods, oscillometric methods, and rheographic methods. Indirect method for check blood pressure. Palpatory methods, blood pressure Rivarocci methods. When the cuff pressure is higher than systolic blood pressure, artery is closed, no pulse can be sensed. When the cuff pressure drops below systolic blood pressure, blood can be passed through the artery and the pulse will be felt. On information, doctor take from palpation of pulse. This method have name palpatory method, which use special tonometer. Next method is auscultatory method of blood pressure measurement. Auscultatory method is a recording of sound in the blood vessels that medical personnel listen to when they measure blood pressure using a non-invasive procedure. If the cuff pressure drops to a level equal to the patient's systolic blood pressure, the fast beep will sound, because the pressure in the cuff is the same as the pressure procedure produced by the heart. Some blood will be able to pass through the brachial artery during systole. the sound head during measurement of blood pressure. The sound head during these methods are not the same as the head, sound lab, and dub that are usually closing to the heart valves. Also, if the cuff of a sphygmomanometer is placed around a patient's upper arm and inflated to a pressure above the patient's systolic blood pressure, there will be no sound audible. This is because the pressure in the cuff is higher enough such that it completely occludes the blood flow. It's similar to a flexible tube or pipe with fluid in that is being pinched shut. As the pressure in the cuff is allowed to fall further, thumping sounds continue to be heard as long as the pressure in the cuff is between systolic and diastolic pressure. As the arterial pressure keeps on rising about and dropping back below the pressure in the cuff. Eventually, as the pressure in the cuff drops further, the sound change in quality, then become muted, then disappear altogether. As the pressure in the cuff drops below the diastolic blood pressure, the cuff no longer provides any restriction to blood flow, allowing the blood flow to become smooth again, with no turbulence, and thus producing further audible sound. The auscultative methods, this Latin listening, uses a stethoscope and sphygmomanometers. It involves an inflatable cuff placed around the shoulder at approximately the same vertical height as the heart, attached to a mercury or aneroid manometer. A mercury manometer measures the height of the mercury column, giving an absolute result without the needs for calibration, and therefore free from the calibration errors in drift that affect other methods. The use of mercury manometers is often required in clinical trials and for the clinical measurement of hypertension in high-risk patients such as pregnant women. On picture you can see these special manometers for check mercury manometers for check blood pressure. A cuff of the appropriate side is smoothly placed on the shoulder, then inflated manually by repeatedly squeezing the rubber bulb until the artery is completely covered. Listening to the brachial artery in the elbow joint with a stethoscope, the doctor slowly reduces the pressure in the cuff. When blood fast begins to flow in the artery, the turbulent flow creates a whistle or thump, the fast sound. The pressure is with this sound is fast head is systolic blood pressure. The pressure in the cuff is further relaxed until the sound becomes audible, the last sound, indicating diastolic blood pressure. On scheme you can see oscillometric methods, automated methods of non-invasive blood pressure measurement. It has some distinct advantage over the auscultatory methods. Sound is not used during measurement. This technique does not require a microphone or transducers in the cuff. Rheographic methods, a fully automatic apparatus for measuring systolic and diastolic blood pressure, has been developed using the ordinary cuff and the principle of rheographic detection of an arterial pulse. The change in impedance at 2 points under the occluding cuff forms the basis of detection of the diastolic pressure. Electrode A and electrode C are placed in a certain distance from the electrode B, one distally and other proximally. Higher frequency current source of 100 kHz as the input. On scheme you can see a rheographic method of direct blood pressure measurement. This scheme registration difference type method through the apparatus. Different point and connection between different point for check amplitude electrical pulse. Next information, when measure the impedance any two electrodes pressurizing the cuff, it shows modulation of accordance with the blood flow pulsation in the artery. In this method, a set of 3 electrodes are placed in contact with the skin. A good contact is essential to reduce the skin electrodes contact impedance. Electrode B, which acts as a common electrode, is positioned slightly distal from the midline of the cuff. This last information about rheographic methods. Next part our lecture is information about arterial pulse. The ultimate expression and recoil of elastic arteries after each systole of the left ventricle, creating a traveling pressure wave which is called the pulse. Reading the pulse. Pulse are manually palpated with finger. The forefinger should be used. Finger must be placed near an artery and pressed gently against a firm structure, usually a bone, in order to feel the pulse. Common pulse site. Radial pulse. This you can see place for check radial pulse. Lateral aspect of the lower forearm, just proximal of the wrist joint. Feel the bony prominence. Move fingertips medially. Tips of fingers drop into a groove of which lies the artery. Examine the pulse by compressing the artery backwards against the bone using the fingertips. Next place, brachial pulse. Medial aspect to the antecubital fossa at the line of the elbow joint. The artery is felt by compressing backwards with finger or thumb through the aponeurosis. Divide just below elbow to form radial and ulnar arteries. Carotid pulse, 1 to 1.5 cm lateral of the midline in the cheek at the upper level of the thyroid cartilage. This position for check carotid pulse. Readily palpable at anterior border of sternomastoid muscle. May be felt with fingertips or thumb, which are used to push posteriorly. Femoral artery. The femoral artery enters the upper leg by passing under the inguinal ligament. It enters the leg at the mid-inguinal points. The femoral artery is usually easily palpated, and it's an important point to access to the arterial system. Popliteal artery. The popliteal artery is palpable in the popliteal fossa. The artery passes through the fossa slightly medially to laterally. The popliteal artery can be poplited in about the midline of the fossa at the level of the femoral condylus. Artery best felt with knee in slight flexion. Next, place tibialis posterior artery. The tibialis posterior artery is found on the medial aspect of the ankle. It's palpable at a position midway between the prominence of the medial malleus and the prominence of the calcaneus. Malleolus and calcaneus. Dorsalis pedis artery. Dorsalis pedis is a continuation of tibialis anterior. Tibialis anterior is often palpable at the ankle joint in a mid-malleolar position, medial to the extensor hallux is longus tendon. Next, information about measuring pulse. Palpation, hand and resting position on the surface, palm up. Feel along the inside to the wrist with your fingertips, locating the radial pulse below the thumb. Don't use your thumb, as it has a pulse of its own. Look at your watch or clock and find a starting point. Count the beats you feel for 60 seconds. Next, information about examination of pulse. During pulse examination, we have to see pulse rate, regularity pulse, quality of the pulse, the thickness and hardness of the arterial walls often can be assessed by rolling the vessels against underlying tissue. Pulse rate. The rate of the pulse is recorded in beats per minute. The rate should be counted over a minimum of 30 seconds. The normal resting pulse rate is from 60 to 90 beats per minute. Abnormal, slow, less 60 minutes per minute. Abnormal fast, tachycardia, more 90 per minute. Pulse rate change with the patient's age. A fast pulse rate for age may indicate arrhythmia or congestive heart failure. A slow pulse rate usually reflects athletic conditioning. However, atrioventricular block or drug effect should be considered. Irregularity of pulse rate may indicate an arrhythmia. However, a change in pulse rate with respiration is normal sinus arrhythmia. Have named sinus arrhythmia. Pulse rates vary depending on age, size of patient, and physical condition. Recorded in beats per minute. Tachycardia. Pulse rate higher than normal, above 100 for adults. Bradycardia. Pulse rates lower than normal, below 60 in adults. Difference for well-conditioned athletes. Remember, normal range adult from 60 to 90 beats per minute. Well-conditioned from 50 to 60 beats per minute, because the heart muscles receive more exercise. For babies to 1 year, normal range from 120 to 160 beats per minute. Children aged from 1 to 10 years ago, from 60 to 140 beats per minute, and children aged from 11 to 17, normal range from 60 to 100 beats per minute. Next, information about regularity of pulse and quality of the pulse. Regularity of the pulse, or the spacing of the beats. Regular or irregular. Regular rhythm. This condition with pulse is felt in a pattern with the same time interval occurring between beats. Irregular, not when beats are unevenly spaced or beats are skipped. About quality, check volume of pulse. The volume of pulse is the crude indicator of the stroke volume of the heart, the amount of blood ejection ejected by the heart. Its increase in exercise, full or bounding, and reduced in state of low blood volume, weak or treat. This condition and information about quality of the pulse. State of the vessel wall, force and tension. The normal arterial wall is compressible and has an elastic field. Diseased arteries may feel inelastic and even hard in case in calcification. Force indicates higher systolic blood pressure, high in hyperdynamic states, low in during shock, cardiac failure, stenotic valvular lesion, cardiac tamponade, and tension indicates higher diastolic blood pressure. Next, information about sphygmography, like non-invasive indirect graphical dynamics methods. Sphygmography is a mechanic cardiographic method of a dynamic record of the arterial pulse in the form and a diagram its analysis. The pressure increase in arteries on every cardiac beat as the vessel's transection grows is observed, then the vessel resets. The whole cycle of transformation is called an arterial pulse, that is caused by the arterial wall pulsation during the passage of the stroke volume through the arterial bed and is recorded in dynamics and known as sphygmogram. Sphygmogram has determined points on the synchronic recording either with electrocardiogram or with phonocardiograms that allows to analyze cardiac cycle phases separately for right and left ventricles. Mostly, two or more piezosensors are simultaneously attached for the synchronic records with electro and phonocardiograms is carried out. Curves recorded from major and peripheral vessels are different. On sphygmogram, this graph registration of arterial pressure and pulse, you can see different waves. Ana crota, A. Ana, up, crotos, push. Is the opening of semilunar valves and moving of blood in aorta. Next wave, B part, kata, crota. Kata is down, crotos push. It has addition wave, dicrotic. It's end of ventricular systole. The pressure in ventricle start of decrease. Next, incisura. Next wave, addition wave, C, or secondary or dicrotic increases. The close of semilunar valves of aorta and push of blood from them. This information about different parts of sphygmograms. Thank you for your attention. Next information.